Morning, everyone. Am I audible, sir?
Yeah, audible.
Sir, sorry, sir. OT run out అందువల్ల లేట్ అయిపోయింది క్లాస్ అనమాట.
Yeah, start చేసండి. Okay, so today's speaker, Dr. Gayatri, has done her DNB anesthesiology from Imambara Hospital, Kolkata, and her special fields of interest are obstetric anesthesia and regional anesthesia. So, okay, Gayatri, go ahead with the class. Thank you.
Okay, sir. Thank you, sir. So today we are going to discuss about the management of the traumatic rib fractures. Traumatic rib fractures occur as a consequence of blunt force trauma to the chest wall, either due to road traffic accidents or fall from heights. In younger patients with isolated rib fractures, it can be managed with simple analgesia. But in older patients and those with significant comorbidities, there is a risk of respiratory complications like atelectasis and pneumonia, which can lead to respiratory failure. And individuals with multiple displaced rib fractures and those with a flail segment have increased risk of morbidity and mortality. Higher risk groups need coordinated multimodal approach to management with focus on the optimal analgesia and respiratory support. Coming to the anatomy, the chest wall is made up of 12 pairs of ribs, and all these ribs are articulates posteriorly with the vertebral column. The first 7 ribs have direct articulation with the sternum anteriorly, while 8 to 10 ribs are attached to the sternum by the costal cartilage. And 11 to 12 ribs are called floating ribs because they have no attachment. A neurovascular bundle runs inferior to the corresponding rib, which consists of intercostal artery, intercostal vein, and intercostal nerve. This is the anatomy showing the arrangement of the ribs. Here 11th and 12th ribs are not attached to the sternum, so they are called as the floating ribs. And we have major vessels here like right subclavian artery, right innominate vein surrounding the first and second ribs. And coming to the mechanism of injury, the most common cause of rib fractures is direct trauma to the chest wall. But in elderly people, simple fall from standing can also lead to the rib fractures. Less common causes include stress fractures and pathological fractures. Stress fractures can be caused by repeated coughing, while pathological fractures are due to underlying causes. Coming to the rib, the structurally weakest part is the posterolateral angle of the rib, but the site of the impact and the degree of the force applied determine the pattern of the injury. In younger children, more force is required because of the relative elasticity issues. So in case of younger patients with rib fractures, we have to rule out the non-accidental injuries. And these are the common patterns of the rib trauma and their clinical significance. Fracture to the first 2 ribs are less common, and it indicates high impact injury. They are associated with higher mortality as well as morbidity because of the potential injury to the major rib. Coming to the displaced fractures, there is a risk of laceration to the lung parenchyma, and they are also associated with hemothorax and pneumothorax. Injury to the lower right ribs can lead to the hepatic injury, while injury to the lower left ribs can lead to the risk of splenic injury. These are the complications like pneumothorax, hemothorax, pneumonia, pulmonary contusion, injury to the major vessels, and intra-abdominal organs. Most common sequel is worsening of the respiratory failure. The most common cause of death is severe pneumonia leading to the respiratory failure. Flail chest. What is a flail chest? Fracture of 3 or more ribs in more than one place, often as a result of high impact blunt trauma. A segment of the chest wall which is no longer in continuity with the rest, and this leads to loss of a mechanical movement of the chest during the normal ventilation. and it causes the paradoxical chest wall movement, where the flail segment moves inwards during inspiration and outwards during expiration, which leads to increased work of breathing and decreased respiratory function. Approximately 10% of all chest wall injuries will have flail chest, and they are associated with mortality of more than 30%. Coming to the assessment of the rib fractures, we require advanced trauma life support style approach because they can be associated with other life-threatening injuries. So we have to assess the patient carefully. In patients with a decreased conscious level either due to head injury or other any painful distracting injuries, identification is difficult. In patients with isolated injuries, there can be localized pain or tenderness or any associated deformities. So we can easily identify the patients. In patients with underlying pneumothorax, they have signs of absence of breath sounds or developing surgical emphysema. If there is any chance of tension pneumothorax, we have to immediately decompress the needle decompression should be done. In case of significantly displaced rib fractures, they can be identified on AP view of the chest X-ray, but undisplaced rib fractures can often go undetected. So the modality of the choice for the chest wall injury is CT scan of the thorax. Coming to the management is mainly based on the risk stratification score, which includes rib fracture score. Rib fracture score is equal to breaks or fractures of the ribs into sides, either unilateral or bilateral, and it also includes the ACE factor. So rib fracture score is equal to breaks into sides plus ACE factor. ACE factor can be categorized into 5 categories. It is given a score of 0 if the patient is less than 50 years old, a score of 1 if the patient is 51 to 60 years old, a score of 2 if 61 to 70 years old, a score of 3 if it is 71 to 80 years old, and a score of 4 if more than 80 years old. A score of more than 7 requires referral to the acute pain team. Pharmacological treatment involves simple analgesics like paracetamol or NSAIDs, and it also involves opioids. Either reasonably well-controlled pain, we can go with oral morphine, and uncontrolled pain, intravenous morphine. Non-opioid analgesics involve gabapentin or pregabalin. This is the algorithm which shows multiple risk fracture pain or management algorithm, and it involves rib fracture scores and also dynamic pain scores. So depending on this, we have to proceed. And these steps 1, 2, 3, 4 are categorized on the basis of the rib fracture score scoring. A score of 3 to 6 is categorized under step 1. A score of 7 to 10 is categorized under step 2. A score of 11 to 15 is categorized under step 3, and a score of more than 15 is categorized under step 4. Coming to the step 1, that is the refractor score is between 3 to 6. We can treat the patient with regular paracetamol and a regular codeine with or without NSAIDs, and with or without oral morphine as required. And in case of uncontrolled pain, that is pain score is 2 to 3, we can proceed to step 2. If the pain gets controlled and the dynamic pain score is 0 to 1, then we can continue with the established anesthesia regimen. In case of uncontrolled pain with pain score of 2 to 3, we have to proceed to step 2, which includes intravenous opioids like morphine at the rate of 0.1 to 0.2 milligrams per kilogram, and titrated doses we have to give, and we have to give anti-emetics because they are having the side effects like nausea and vomiting. And if the pain gets controlled with a dynamic pain score of 0 to 1, we can proceed with paracetamol with or without NSAIDs, and morphine sulfate slow release tablets 10 to 20 milligrams twice daily, or oral morphine 10 to 20 milligrams. In case of uncontrolled pain with or without high risk group, we have to proceed to step 3. Step 3 involves intravenous morphine, patient-controlled analgesia, gabapentin, and antiemetics. If the pain gets controlled in case of step 3, we have to proceed to dynamic, continue step 3, and we have to give regular paracetamol with or without NSAIDs. And if the pain is not controlled and it is uncontrolled pain, we have to proceed to step 4. And step 4 includes regional anesthesia blocks and some surgeries like rib fixation, and we have to contact the pain team. And from step 3 and step 4, we have to go for follow-up for acute pain team. And while considering NSAIDs, we need to be conscious or we have to consider contraindications, because in elderly patients, it can lead to renal failure. Dynamic pain score refers to pain associated with deep breathing and coughing. Pain score 0 means it is none, and 1 it is mild. If it is 2, it is moderate, and if it is 3, it is severe. Coming to the regional anesthesia, patients who are unable to deep breathe or cough despite the pharmacological treatment, we will proceed with the regional anesthesia. And these include some types of blocks like thoracic epidural, thoracic paravertebral block, intercostal nerve blocks, erector spinae plane block, and serratus plane block. This is the table which shows the regional anesthesia techniques. It is a summary, and these include mainly 5 types of blocks. Thoracic epidural. It is a neuraxial technique. It is a traditional approach, but with recent techniques, it is decreasing popularity. In this, we can give either continuous infusion via the epidural catheter. What are the benefits? It provides bilateral analgesia. It is an established technique, and it has superior pain relief over the other techniques. But it also has some drawbacks, like it is contraindicated in coagulopathy diseases and requires expertise to manage safely. And it has some side effects like hypotension, urinary retention, and motor weakness. Coming to the thoracic paravertebral block, its clinical application is it is used to provide unilateral analgesia. Mainly, it covers the posterior rib fractures. It can be maybe single shot or bolus or continuous infusion via the catheter. It has some benefits like it provides unilateral analgesia. It is an established technique, and it has reduced hypertension when compared to the epidural, thoracic epidural. And it has some drawbacks like it is relatively contraindicated in coagulopathy. It has a technically challenging procedure because of catheter insertion, and it has some side effects like pneumothorax, inadvertent epidural spread. Coming to the intercostal nerve blocks, it mainly relies on multiple injection at levels of the fractured ribs. It has coming to the benefit, it is a relatively simple technique. Coming to the drawbacks, it has limited duration as single shot. There is a risk of pneumothorax, and high systemic absorption of local anesthetic can lead to LAST. Coming to the erector spinae plane block, it is a facial plane block. It is used to provide unilateral analgesia, mostly covers the posterior fractures. It can be given single shot or bolus or continuous infusion via the catheter. Coming to the advantages, it is relatively easy block to perform. It can be considered safer in coagulopathy when compared to thoracic epidural and paravertebral block. It has reduced complications like hypotension when compared to the epidural. But it also has some drawbacks because of variable spread of the local anesthetics, and it requires ultrasound to aid insertion. It is of limited good quality evidence base and novel approach. Serratus plane block, it is also a fascial plane block. It is used to provide unilateral analgesia, mostly covers the anterior fractures, maybe single shot or bolus or continuous infusion via the catheter. It has some drawbacks because of it has some benefits because of easy block to perform. It can be considered safer in coagulopathy than epidural or paravertebral block like erector spinae block. It has a reduced risk of hypotension when compared to the epidural blocks. And it has some drawbacks because it is not suitable for posterior rib fractures. It can only block the anterior fractures. Variable spread of the local anesthetics, requires ultrasound to aid insertion, and it is of limited good quality evidence base, and it is a novel approach. Coming to the thoracic paravertebral block, paravertebral space is a wedge-spaced shaped space located on either side of the vertebral column. It has some boundaries, like anterolaterally it is bounded by the parietal pleura, the pleural space, visceral pleura, and lung parenchyma. Medially, it is bounded by the posterolateral portion of the vertebral body, the vertebral disc, the vertebral foramen with its corresponding spinal nerve. And posteriorly, the superior costotransverse ligament and intertransverse ligament. And laterally, the posterior intercostal membrane and the intercostal space form its boundaries. Thoracic paravertebral space is the fatty tissue. which consists of mainly the intercostal nerve, the dorsal rami, the intercostal vessels, and the sympathetic chain. This shows the paramedian sagittal. I mean, thoracic paravertebral block can be given either in the transverse approach or the paramedian approach. It mainly blocks the trunks of the intercostal nerves. In sagittal position, local anesthetic is deposited inferior to the superior costo-transverse ligament. And in case of transverse approach, local anesthetic is deposited deep to the internal intercostal membrane. So while going to the paramedian sagittal approach, we have to pierce the skin, subcutaneous tissue, and paraspinal muscles like trapezius, rhomboides, and then we proceed to the superior costo-transverse ligament. So this forms the main thing, and inferiorly to the superior costo-transverse ligament, we deposit the drug here. And we have to be careful about the pleura and the superior costo-transverse ligament. Inferiorly, we have this paravertebral space. It can be given in the sitting position, prone, or lateral position. Coming to the erector spinae block, erector spinae muscles extend from the base of the skull to the medial crest of the sacrum. From medial to lateral, there are three muscles like erector spinalis, longissimus, and iliocostalis. The main aim of the block is the compartmental spread. Efficacy of the block depends on the local anesthetic agent passively distributing within the plane to reach the target nerves. And extent and quality of the block depends on the absorption and diffusion of the local anesthetic across the tissue planes. Because of the discontinuity of the intercostal muscles, local anesthetic passes through the intertransverse connective tissue and it diffuses anteriorly to the ventral and dorsal rami of the spinal nerves, and from there it enters the thoracic paravertebral space. So this is the ultrasound guided block, and in erector spinae block, the main thing is we have to identify the transverse process. There are many approaches for ultrasound guided blocks like classic approach, rack approach, Tulgar approach, AXU approach. Tulgar and AXU approach are mainly used for the lumbar erector spinae blocks, while the classic approach and rack approach are mainly used for the thoracic things. And we have to place the we mostly used is the parasagittal position of the probe, and we have to identify the spinous process, and from there we have to move the probe laterally 2 to the 3 centimeters away from the spinous process. In classical approach, we can see 3 signs like horse head sign, camel hump sign, trident sign. Horse head sign is formed by the lamina because of the slope followed by gap, slope followed by gap. And moving laterally, we can see the camel hump sign, which is formed by the articular process, where we can see the sawtooth appearance. And from there, we can see the trident sign formed by the transverse process. While performing the erector spinae block, we will pierce the skin, subcutaneous tissue, subcutaneous fat, trapezius muscle, rhomboides muscle, and erector spinae. And then below the erector spinae, after piercing the erector spinae, we will deposit the local anesthetic just above the transverse process. And there are 2 types of erector spinae block, either superficial erector spinae or deep erector spinae block. Normally, we perform the deep erector spinae block, where the drug local anesthetic gets deposited between the erector spinae muscle and the transverse process. In superficial block, we will deposit the drug between the erector spinae muscle and the rhomboides muscle. And here transverse process and RIP look similar in case of ultrasound guided blocks, but we have to differentiate between the two. The transverse process is superficial and it is more square in shape, while the RIPs appear as more round in shape, and they are the deeper structures. In classical approach, the drug spreads either in the laminar or facial separation process spread. In rack approach, it is called as rack approach because the muscles and transverse process seen arranged in the rack manner. rack approach is mostly transverse scan. It has some advantages over the classic approach because the injectable drug is seen as a circular collection, and we can clearly identify between the transverse process and rib. Rectus spinae plane block can be given either a single technique or continuous technique. In single technique, 5 centimeters, 8 centimeters, or 10 centimeters, 22 gauge or 23 gauge needle can be used. And in continuous technique, 18 gauge or 16 gauge 2 needle can be used. In single technique, either bupivacaine or levobupivacaine 0.24% and or ropivacaine 0.35% can be used. In continuous catheter technique, we will use the bupivacaine of 0.125% or ropivacaine of 0.2% at the rate of 5 ml per hour. And it can be used with patient-controlled boluses of 6 or 8 ml with a lockout interval of 60 minutes. So it shows the weight-based local anesthetic concentration on volume guide for erector spinae plane block in rib fractures. Coming to the serratus anterior plane block, the mainly targeted nerves are the lateral cutaneous branch of the intercostal nerves and also nerve to serratus anterior and thoracodorsal nerve. So coming to the ultrasound guided blocks, it can be given either the superficially or deeply, but superficially we will proceed. And while giving the serratus anterior plane block, we need to be careful not to puncture the thoracodorsal artery. In case of serratus anterior plane block, we will deposit the drug between the latissimus dorsi and the serratus anterior muscle. In case of deep block, we will deposit the drug between the serratus anterior and the intercostal muscles. So this white arrow shows the deposition between the latissimus dorsi and the serratus anterior muscle. This yellow arrow shows the between the serratus anterior and the rib. That is deep deposition. So in case of serratus anterior plane block, the patient can be kept supine with arm abducted to 90 degrees or lateral. And ultrasound probe position is by placing the probe in a parasagittal plane immediately inferior to the clavicle and in the deltopectoral group adjacent to the coracoid process. And we have to move the probe inferiorly and posteriorly until the fifth rib is found in the mid-axillary line. We need to be cautious about the thoracodorsal artery. We should not puncture the artery. In case of needle technique, prior to the insertion of the needle, we need to identify the location of the pleura. We have to introduce the needle in plane, advancing it from the supero-anterior to the postero-inferior direction. In case of local anesthetic of 0.3 to 0.4 ml per kilogram of 0.25% levobupivacaine can be used. And refractures also include supportive treatment with chest physiotherapy, that is incentive spirometry or pulmonary toilet to clear the secretions. And in case of associated pneumothorax or hemothorax, we can proceed with intercostal drainage tubes. ICD is a big topic, so I'm not discussing it here. And we require close monitoring in case of high-risk cases. Those with increased oxygen requirement, worsening tachypnea, and increasing PaCO2, we have to proceed with intubation and invasive ventilation. Patients not suitable for treatment escalation, we have to proceed with non-invasive ventilation or humidified high-flow nasal oxygen. Thank you.
Hello, good morning all. Madam, Dr. Gayatri, madam.
Sir.
Madam, small one question, madam. Among all the ultrasound procedures and regional procedures you have mentioned, which is most preferred, madam, for any rib fracture or anything? Most commonly practiced?
Sir, nowadays they are performing serratus anterior plane block and erectus spinae block, sir. Because ultrasound preference is growing, so.
No, I doubt erectus spinae, madam, because you need to change the patient's position, no? With rib fracture, I don't think patient will be in a position.
Sir, it can be performed posteriorly, sir, erectus spinae
Yes,
block,
madam.
while
That's
sitting
what I meant.
position.
Because with,
And we'll be asking the patient to lean forward. Of course, there is some trouble.
We give intercostal, madam, ultrasound guided. I think that is a bit easier, na?
Yes, sir.
Below the rib margin, we deposit drug, na, madam?
Yes, sir. Yes, sir.
In the literature about this technique, which is most preferred, madam, like what are the advantages of preferring this apart from patient comfort?
I don't know, sir, but I will search and will tell you, sir.
The maximum amount of maximum relief ఈ ప్రొసీజర్ చేస్తే వచ్చింది అలాంటిది ఏమైనా ఉందా మేడం మరి?
ఐడియా లేదు సార్, నేను ఒకసారి సెర్చ్ చేసి పంపిస్తాను సార్.
ఆల్వేస్ విత్ థొరాసిక్ ఎపిడ్యూరల్ మాక్సిమం.
Yes sir, thoracic epidural maximum, but
like అంటే థొరాసిక్ ఎపిడ్యూరల్ తో బైలాటరల్ బ్లాక్ అవుతుంది మనకి యాక్చువల్ గా చాలా కేసెస్ అవి. సో ఇన్ దోస్ కేసెస్ ESB అంటే యాక్చువల్లీ like ఆ సైడ్ బ్లాక్ చేయాలి. యూ కెన్ డూ ఎయిదర్ ఇన్ సిట్టింగ్ ఆర్ లాటరల్ కూడా చేయొచ్చు. లాటరల్ కూడా అప్పుడు ఆ ఫ్రాక్చర్డ్ రిబ్స్ పైకి వస్తాయి కాబట్టి దాని మీద కంప్రెషనే ఉండదు. బట్ అగైన్ ద ప్రాబ్లమ్ విత్ దిస్ బ్లాక్స్ ఈజ్ సింగిల్ షాట్ బ్లాక్ ఒకటి ఇస్తే డ్యూరేషన్ 12 to 16 hours ఉంటుంది, మళ్ళీ ఇంజెక్షన్ చేసుకోవాలి. If you have expertise enough, ESB catheter, ESB with catheter, I think is the best option for rib fractures, unilateral. If bilateral rib fractures are there, then obviously thoracic epidural is the best technique. And paravertebral block లో కాన్సన్ట్రేషన్ ఎక్కువ అబ్జార్బ్ అవుతుంది, సో మల్టిపుల్ లెవెల్స్ చేయలేము. సో సేమ్ ప్రాబ్లమ్ విత్ ఇంటర్కాస్టల్ నర్వ్ బ్లాక్, అబ్జార్ప్షన్ చాలా ఎక్కువ ఉంటుంది లోకల్ అనెస్థెటిక్ది. సో 3 levels కంటే ఎక్కువ చేసామంటే షీ టోల్డ్ లోకల్ అనెస్థెటిక్ సిస్టమిక్ టాక్సిసిటీ వెరీ హై ప్రాబబిలిటీ. సో 3 levels లోనే చేయగలం ఇంటర్కాస్టల్ బ్లాక్ మ్యాక్సిమం. సో దట్ విల్ కవర్ అరౌండ్ 3 to 4 levels మ్యాక్సిమం. 3 to 4, 2 to 3 rib fractures అయితే ఓకే, కానీ లైక్ 4 or 5 ribs or 6 ribs అలా ఇరిగితే మాత్రం ఇంటర్కాస్టల్ బ్లాక్ పెద్దగా యూజ్ ఉండదు. ఈఎస్బి జనరల్లీ వీ విల్ సీ వాట్ రిబ్స్ ఆర్ ఫ్రాక్చర్డ్ అండ్ ఆ వెటిబ్రల్ లెవెల్స్లో కరస్పాండింగ్ వెటిబ్రల్ లెవెల్లో మిడ్ పాయింట్ చూసుకొని జనరల్లీ వీ గివ్ సో దట్ ఇట్ విల్ స్ప్రెడ్ ఇన్ లైక్ బోత్ అప్వర్డ్స్ అండ్ డౌన్వర్డ్స్ డైరెక్షన్ బేస్డ్ ఆన్ ద టెక్నిక్. అంటే లాటరల్లో చేస్తే అలాగా, ఇఫ్ యూ డూ ఇన్ సిట్టింగ్ యూ గివ్ మోర్ టువర్డ్స్ ద సర్వైకల్, అంటే మేబీ అప్పర్ లెవెల్లో కొంచెం ఇస్తాం అనమాట. థొరాసిక్ పారావెర్టిబ్రల్ తక్కువ లెవెల్స్ ఇవ్వాలి. అది దట్స్ ద ప్రాబ్లమ్ విత్ థొరాసిక్ పారావెర్టిబ్రల్ అండ్ ఆల్సో ఇంటర్కాస్టల్ బ్లాక్. సో ఐ థింక్ the preferred techniques can be ESB with a catheter and thoracic epidural. Whatever we talk at the end of day, literature కోసం చాలా మాడచ్చు, కానీ అంటే the number of techniques and the wide variety, but the most I mean like useful with very less this one only. Serratus anterior actually without ultrasound also it can be very easily given landmark. సో మిడ్ యాక్సిలరీ లైన్ చూసుకుంటాము, 5th rib ఐడెంటిఫై చేస్తాము, యూ గో అండ్ హిట్ ద రిబ్, కమ్ అవుట్ ఫ్యూ mm and give. సేమ్ విత్ ఎరెక్టర్ స్పైనే, Even without ultrasound, you hit the transverse process, come out and give. So just like previously what we used to give for supraclavicular and all. So allow you can just come out and give them, not the like very complicated stuffing, the rectus spinal block and the serratus anterior plane block. So those are my thoughts. The best options, if you ask me, I will say these two. Rectus spinae with catheter, without catheter, again there is no point. Prati 12 hours ki podustanante patient ninnu podustadu. So with catheter and thoracic epidural. Fentanyl patch or fentanyl or whatever analgesic patch is another option. But again, if the patient is in ICU, it's absolutely fine. You will be monitoring him. But if the patient is in floor, you can sometimes end up in soup. And fever spikes can have fentanyl absorption, as you all know, transdermal patches. So that's the problem. Or if the patient is in ICU, there is no issue. And you can use a transdermal patch. And most of them are trauma cases and they get some sort of infection, fever spikes, inflammation. These are my thoughts about management of rib fractures. Thank you.
Sir, is it same with 11-12 ribs also, sir? 11-12 ribs మిగతా వాటిలో ఇంక్లూడ్ అవ్వదు అనుకుంటా కదా ఈ సెరేటస్ వాటిలోని, and a bit difficult also to give intercostal in that areas also.
11-12 ribs కూడా అంటే erector spine will work. Serratus anterior కొంచెం కష్టం, అంతవరకు ఎక్స్టెంట్ ఉండదు అనుకుంటున్నాను. Very inadequate. Erector spine, there are literature even they suggested for lumbar spine surgeries post-op analgesia ki. Erector spine block, they will give even for L4, L5 laminectomies, L5 laminectomies, like that. So L3, L4, L5 laminectomies kuda erector spine block is suggested for post-op analgesia. So ESB will work. SAP, I don't know. I don't think that will come so far down. But only if 11-12 are fractured, then it is very safe to give, easy to give intercostal block. That will be the most preferred one, and you can keep an intercostal catheter too. So if it is trauma and it is causing distress, always catheter is the preferred one. But again, you have to see with thoracic catheters, dislodgement chances ఎక్కువ ఉంటాయి. So అవి చూసుకోవాలి అంత మెయిన్.
Okay, sir. Thank you, sir.
Good morning to all. Dr. Gayatri, very nice presentation. And next, I'm adding only one point only. If rib fractures or flail chest, in our institute, we are regularly using thoracic epidural because it gives analgesia and psychologically patient also reduce the pain, and he's also able to do spirometry and easily wean off the NIV and oxygen, easily wean off the ventilator also, and later on physiotherapy and spirometry also easily can do. So we can easily get on the ARDS or anything, because sometimes during trauma, lung contusions are there, rib fractures are there. During pain, patient is unable to do anything. Regularly here using thoracic epidural.
Yes,
paravertebral, I don't know, no idea about that one. Any experience, Srikanth and Omkar, Rani madam?
Madam, erector spine, madam, paravertebral, all these again the same problem that I mentioned. Paravertebral and thoracic paravertebral absorption ఎక్కువ ఉంటుంది మేడం, డీ బ్లాక్ అది. సో ఆ మల్టిపుల్ రిఫ్రాక్చర్స్ లో ఎక్కువ లెవెల్స్ లో ఇవ్వలేము మేడం. సో అంటే పర్సనల్లీ ఐ వుడ్ ప్రిఫర్ ఈఎస్బి విత్ catheter or thoracic epidural maximum times I also prefer. ESB with catheter ఒక కేస్ madam, and single shot block for 2 or 3 I mean like ఆ patient కి ఒక patient కి like 16 hours ఆ gap లో ఒక 2 to 3 times ఒకసారి ఇచ్చి అలా మేనేజ్ చేస్తాం. After 1.5 days he settled somehow with IV analgesia and erector spine, but hardly we have done around 2 to 3 cases erector spine. Majority of my experience over the past 10 years is with thoracic epidural only. Remaining blocks, I don't think they're much effective like that. In my opinion. Even I agree with you.
Thank you, Shrikant and Gayatri. Any questions?
Thank you, ma'am.
Oh, actually, I just want to add something. Sometimes practical problems will be there for placing the thoracic epidural. I think it is a little difficult to place the catheter in the ICU setup.
Yes, madam.
We
Also
have to literally, because of alpha, that bed, soft bed and alpha bed or whatever it is, and with the bed structure, it is difficult. I think better to be placed in the OT only, on the OT table. And maybe because of severe pain, patient may not cooperate also. Sometimes they're short stature and some surgical emphysema. It may be difficult sometimes. So has anybody tried using ultrasound for placing the epidural catheter or something?
not for depth, but for identification of space, I have used a few times, madam.
Okay. So I think we should practice for spinal anesthesia. Then only we can use it for placing.
Madam, mostly.
Shrikant, they try to teach a spinal and epidural under ultrasound. Just to keep one short videos, we have to do like that because we are not experienced. No? But younger generation, everyone is experienced.
ఇప్పుడు వీళ్ళందరూ ఇంకా యాక్చువల్గా వీళ్ళే బాగా చేస్తున్నారు మేడం నాకంటే. అది ఐడెంట్ అంటే ఎపిడ్యూరల్ స్పేస్ తెలియాలంటే కొంచెం మెషిన్ కూడా బాగుండాలి మేడం డెఫినెట్ గాను. సో ఆ డెప్త్ లో తెలియడానికి. బట్ ఐ థింక్ స్పైన్ ఐడెంటిఫికేషన్ అది ఈజీయే మేడం. జస్ట్ క్యామెల్ హంప్ సైన్ అంటారు. సో మనం అలా లాంగిట్యూడల్ యాక్సెస్ లో వెళ్తే బోన్ ఆబ్వియస్లీ రిబ్స్ కనబడినట్టే కనబడుతుంది. మధ్యలో స్పేస్ చూసుకొని అది ఈజీయే మేడం. యాక్చువల్ ఐడెంటిఫికేషన్ ఆఫ్ ఇంటర్లామినార్ స్పేస్ ఇస్ ఓకే చేసుకోవచ్చు. బట్ లైక్ ఈ ట్రాన్స్ఫర్స్ ప్రాసెస్ ఐడెంటిఫికేషన్స్ అవి కూడా వస్తే ఎరెక్టర్స్ పైన అవి ఇవ్వడానికి ఈజీగా ఉంటుంది మేడం యాక్చువల్లీ. సో ఐ విల్ సీ ఇఫ్ సమ్ వీడియోస్ ఆర్ దేర్, గుడ్ ఆర్ దేర్, విల్ పోస్ట్ దెమ్. Sure.
Sometimes occasionally Dr. Shekhar will do. Difficult spinal or epidural, sometimes he is doing.
Omkar is also, I think Sarath in Pinnacle, all these are using good use of ultrasound. Chaitanya.
Chaitanya is very busy, Babu.
Okay. Any more questions and all, or we'll wind up the class? Shekhar ochada. Shekhar, good. Okay. Next week, DNB students, I will inform Shekhar this week. Okay. Thank you, Gayatri. It's a nice class, and we had a nice discussion on this. Thank you so much.
Yes, sir. Thank you, sir.
Thank you to all. Thank you, Gayatri.
Thank you.
Thank you. Thank you, Gayatri.
Thank you, ma'am.